Okay, well, it looks like everybody's here. So good afternoon and good morning, everybody. We're just letting a few people join the room before we kick off today's session. For those of you that joined us with our last webinar, this is going to be a slightly different emphasis today. We're going to be more focusing on clinical technique. So I'll introduce our speakers in just a short while. As you can see, if you have any questions as we go along, please pose those questions via the chat facility in the bottom of your screen, and feel free to do that as we go along. And what we'll do is we'll address those questions as we go through. Okay, so next slide, please. So yeah, as I mentioned earlier, today is really going to be focused on the case study elements of the work that's been happening with the Insight system with one of our leading partners, Prosthetic Orthotic Associates. And today we're going to be joined by one of their key prosthetists, Cassandra Delgado. Hey, Cass, good morning to you.
Good morning.
So Cass, would you like to introduce yourself to everybody?
Sure. Yeah, I am currently a CPO practicing in Middletown, New York, about an hour or so north of the city. I did my prosthetics residency here, did my orthotics at University of Michigan, and I've been at the practice now since 2017 and have just really enjoyed working here. I am just a basic CPO in the trenches like a lot of the rest of you guys are. Day in, day out with a full patient load. And so I was given the opportunity to try this system and use this system in our clinic as a demo. And it's been really interesting just from my experience. And we'll talk more about it today. Just the improvements that are always happening in our field. And it's exciting. It's exciting for me to be able to share that. So I'm currently an assistant clinical director here, and I oversee the lower limb prosthetic and lower limb orthotic branch of the practice. So.
Great, Cass, well, it's lovely to have you here today. And we're also joined by Fred Carpentiero, our CEO. And Fred will be doing a demonstration for us in a short while. So if I just talk you through the Insight system, if we could go to the next slide, please. Yeah, so you can see there that on the left-hand side is the 3D scanner. And I'd like to just really emphasize that this is not about 3D scanning technology per se. The 3D scanner is an integral part of our system. But as you'll see when we go through the demonstration, there is way more to the system than just the scanning element. So we also have the biosensors, which go within the socket to provide a lot of the information that you'll be seeing through the demonstration. Plus, of course, there is a wearable device, which is based on a Bluetooth technology, which then works directly with the application. And the application is running on the iOS system, so it sits on an iPad. And you can see that integrating all of these four elements together, that is the overall system, which is what we call the Insight system. And as I say, there'll be a full demonstration on that in a short while. So the key thing really is that the sensors go inside the socket, as you'll see in a short while. And then the sensors and the socket go in the 3D scanner so that the exact proportions of the inside of the socket and the location of the sensors can be mapped into the system. So the app also drives.
Hello, William.
So the app will be the thing that absolutely drives both the scanning activities as well as the patient input. And then you can see that while the scanner is working, we can be using the app to update that with all the system's information about the patient. But the key thing is when the patient puts the socket back on, we then get a range of very important information that comes back to the prosthetist in the clinical session to be able to identify how that socket is performing both for the patient and in terms of what the patient is feeling and perhaps actually what they're not feeling. And the key thing is really that this system is all about optimization. And as you'll see, we're looking to reduce clinical time. This is all about efficiency and comfort for the patients. And we'll be going through the details of this as we go through today's session. Next slide, please. So these are the positions of the sensors. Now, Cass, you're the person that does a lot of this work. So maybe you could just talk us through a little bit about how are these positioned and why you positioned them in these positions.
Sure. So a lot of questions I get asked frequently are, well, how many sensors can you put in, or where can you put them, or is there a limit to it? I personally have never had opportunity where, or a situation where there's not enough sensors. I'm always able to add sensors in, and it really depends on what you're looking at, right? If I just want to look at my AP, making sure I have a nice snug AP, and I'm just going to put one in the anterior and one in the posterior. Oftentimes I find I'm placing four, an AP and an ML, just to see what my contact looks like. I want to see an even distribution along all of those. The one on the very right picture kind of has one in the center, two on our pretibial sections where you would, add your pretibial pads or your rotation control there. And the nice thing about these sensors is that they're in different lengths. So if I really want to get all the way down to the bottom of the socket, I can get all the way down. If I just want to look at my condyles, I can just look at those. If I want to look at all of it, I can look at all of it. So sensor placement and amount of sensors is something that I'm just asked a lot about. And fortunately, I haven't experienced a situation where I wish I had more sensors and couldn't. The amount that you can add is quite a bit. So, yeah. So with the app, I really like, there's a few different features in the app that I like, but the first thing is that you can get data while your patient is walking. You can see it right away. You don't have to wait for it to process. It's a live feed to you. And so that's been really, really helpful to watch them walk and watch the iPad. Sometimes what I'll do is I'll still use my clinical eye. I'll still watch them walk. I'll have them wait a second and I'll look at the iPad and replay it back. So you can play it back after you've collected some of that data or while it's live, either way. For the resident that I work with, we slow it down. So we slow it down to half the speed, and then we'll watch them and talk about it together. The other really great thing is that it can export into an STL file. So with a cast, let's say if I have a cast or a check socket, I can scan that, upload it to an STL file. I do probably about 75% of my modifications through CAD and the other 25% through plaster. So it's really helping to get that file uploaded into our CAD systems. And then the nice thing is that a pressure report can be generated. So I'll use these to compare before and after we make adjustments, or with an old socket that maybe a patient came in with from another facility, we'll run that through just so we have a baseline understanding of how their current socket fits, separate from just what I can see with my clinical eye. Next slide, I think. Perfect.
Great, Cass, thank you. So what we're going to do now is we're going to go through a video demonstration of the complete system, and Fred will give us a voiceover to that and explain each of the stages to us. So over to you, Fred. Thank you.
Okay, thank you, Phil. So here we'll be looking into a BK amputee. And the first step is obviously to get the prosthetic and disassemble the socket from the rest of the componentry. Once we have that, we clean the socket and prepare it to receive the strips. The strips have a reusable silicone-based adhesive, so you just press them against the socket in the locations that you want, and they will stick in place. And as Cass has said, you can position as much as you want and in the locations that you want to cover any problems that you might be looking or any specific regions. You then get the socket with the strips inside the scanner. It has a self-centering grip, so you can just position the socket inside, press the close button, and it will stop once the socket is properly centered. From that point, then you move into the app that will control the entire system and allow you to see the results. Press add a new scan into an existing patient, select the type of amputation, and it moves you to the scanning screen. You select the scanner that you want to use, press connect, and the scan will start. So the physical scan itself will take about 90 seconds, and then you have to wait about 60 to 90 seconds more to get the processed image back. While you're waiting for the physical scan to happen, you can fulfill other information such as the range of motion, as you can see here. And this is all iOS native based interaction. So it's quite intuitive and easy to use. You can then also add the patient information, such as the weight, the height, and then you can add any notes you want. And this is mostly important if when you generate the report at the end, to get all these informations compiled into the same place. Then you can also take some pictures of the residual limb or of the socket itself by pressing the photo. So you can scan through these different informations through the left side menu. You'll see here now that the information will change, and you'll see that the scan is now complete and you're waiting for processed results. So you can now remove the socket from the scanner. This is the final result. So after you get the processed result, you get a 3D model of the inside of the socket, and you have the location of each of the sensors, which are these white dots. You can manipulate the 3D model however you want, and then you can measure the perimeters at different heights. You have the ruler on bottom that allows you to do this function. Then if you press the export button, it also allows you to export the STL file even before you get the pressures. So after this, you can get the socket out of the scanner, get it into the prosthetic again. And the next step will be to get the patient walking wearing the prosthetic. So once you have that, you will put the wearables on the patient. So we'll have the main unit around the socket, where you will connect the sensors, and the smaller unit on the opposite portion of the leg. So in this case, it will be on the thigh. Then connect all the sensors to the main unit. And you turn on both units of the wearables. Once you have that, you add a new acquisition in the application, select the wearables, press connect, and you'll immediately see the pressures appearing in the sensors. So here you can see the patient making different static positions, and you can see the pressure shifting from one side to the other as he does it. So after that, you can do the dynamic acquisition, and here we are seeing the patient with an unaligned prosthesis. So here you can clearly see that the pressure is not evenly distributed, and you have 2 points that are always with more pressure than the rest. And you can also see that this patient has a loose fitting, and that's his own preference. So he prefers to have a looser fitting on the socket. So then we rectify the alignment, and you can see these changes happening even in the static as you are doing them in the static analysis. And now you can see that you have a more even pressure distribution. So you can see that those pressures are more dispersed through the entire socket. And here we are recording the data, because if you do that for 2 minutes, you'll be able to see an average pressure for each of the gait phases after that. So since this patient had a loose fitting, we asked him to try triple-eye sock to see if it improved. And you can see that now you have much more contact throughout the entire socket. And the patient didn't even want to hear about it. And once he tried and saw the difference, he actually asked the prosthetist to take the sock home and try it when he goes out for some walks, because it is actually more comfortable for him. So that's one of the benefits from having this, that since you can show the patients the impact of what you're doing, they end up being more open to changes and to try different things that can actually be more beneficial for them. And here it's the average result. So after you do that dynamic acquisition, you can see the average pressure by gait phase, or the combined stride of each of those averages. And then you can also see the entire recording you have done, where you can see the animation of the amputee walking synchronized with the pressures. When you have the arrow, it means that the patient is turning, and then you see the patient walking and it's all synchronized, and you can once again export the STL model. If you press the report button, you'll get the PDF report that we've talked in the beginning, where you have different views from all the averages. You have the patient information on top, and if you have notes and pictures, they will be added on the bottom of the report. And in terms of the how to use it and what the system does, it's pretty much this. So it's very simple to use. And the benefit is that you can actually spend less time with each patient and pinpoint problems faster and know exactly what you need to rectify and where. You can store the patient data digitally, so you'll know what all the changes that have happened in the patient residual limb and in the socket shape. It's a good tool to train younger prosthetists that don't have as much experience. It's a good way of getting objective data to support your insurance claims. And in the end, it ends up being a more cost-effective workflow. It's also a very engaging tool for the patients, and I think that's where we've seen most of the value. And I think Cassandra will talk about that too in next slides, because the patient being able to see what's happening really helps him explain what he feels and understand the concepts that the prosthetist is explaining to him. And it really improves the understanding between the two parts involved.
That's great, Fred. Thank you. So obviously, we have an opportunity for questions at the end of the session. So please feel free to pose those questions during the session now with the chat. We'll hold those questions till the end. So Cass, you've been one of the people that's been using the system probably the longest in the US. And obviously, you've got great experience with your patients now. So I understand you're going to take us through a little bit of the technique as well as the outcomes that you've associated with a couple of your patients.
Yeah, absolutely. The first case study I think we'll go over is Chris, and she is a very sweet patient and just one of those tricky, challenging users that you have to do a lot of education with and a lot of reminding and a lot of explaining. But I had a really good outcome with her using the Insight system. And what I've learned also over the past almost 2 years now of me using the system is that it's not meant for just your tough patients. It's not meant for just your easy patients. It's really for any of your patients. You don't have to have this crazy shape or unique case that you would only use it on. It really can be applied for any one of your patients. And I've found that to be true time and time again, where I'm like, well, this is a simple patient. Should I use it? And then I use it and I'm like, oh, that totally helped me there. So anyway, Chris is a great case to show you. I felt like it really helped with just improving her socket fit and alignment. So a quick background on her: she had her amputation because of a failed knee replacement surgery, which caused an immediate amputation to need to occur about 3 days post-op from that failed knee replacement. And because of the complications, she has no patella and a partially reconstructed knee joint that they set in about 18 to 20 degrees of valgum. She has extreme volume fluctuations and about a 3-inch long tibia. And then distal to her tibia, she has about 3 inches of excessive tissue. She's definitely a candidate for a revision surgery, but they've pretty much said that they'd prefer not to do a revision just because of her compromised knee joint structure and being concerned that they would want to, being concerned that they would further injure that if they went back in and tried to remove some of that tissue. She's just kind of had quite a bit of runaround with the experience of amputations, and it's made her very, very anxious as a patient. So taking my time with her has been very, very important. I had previously fit Chris with an adjustable BOA system, which worked really, really great for her. However, this socket replacement, she just needed more stabilization. She was trying to get a little bit more active. And so with this, I added a few more dials. I added another dial and another pad for volume control and more stabilization at the ML. Chris also struggles with being able to express to me or tell me what she's feeling within her socket because of her compromised limb shape and amputation. And so she has a hard time sometimes communicating where she's feeling things at or what exactly she is feeling. So we can click on over to the next slide. All right, so with Chris, her prosthetic design had that BOA system, those adjustable sockets, which I've started using a few more of them, and I've been pretty happy with the outcome of them. But I'm still optimizing, still learning things as I'm stringing and choosing my placement panels and all of that. So her design included adjustable windows at the pretibial region. So I had 2 pretibial pads essentially to create more of a lock on that tiny little tibia that I'm working with, an adjustable window in the gastroc, and then one along the medial proximal trim line. I did a removable medial brim design using BOA, and if you haven't used that yet, it's really, really great compared to the old school ones that clip in or clip out, or having to create a stovepipe type of P-light liner and then they don it. And so anyway, just side note, it worked really great for Chris, and she has a lot of redundant tissue around her knee joint, and so as she fluctuates volume throughout the day, she's able to tighten up that ML section, and that's really helpful for her for that stabilization. So I put sensors on all of the window cutouts. So where her 2 pretibial pads were in the gastroc section, a medial and a lateral, and then also one dead center right along the tibia, the anterior tibia, just to be able to keep an eye on that. So when I used Insight for her, one, it was just explaining it to her and letting her feel comfortable with the system, knowing that she's very hesitant at doctor's offices. She feels very nervous. She gets pretty anxious when she's there. And sometimes she's anxious during our appointments too, because she feels like she may have a difficult time communicating what she's feeling. And that can kind of work her up and get her to a point that's just frustrating for her. So when I was showing her all of these, the sensor pads, and asked her, hey, let's do this. Let's see what this tells us. She instantly had this sense of relief, because she was like, I have something to help us, right? We have this system that can help say what I can't, almost. So it was really interesting to kind of watch her light up when I told her, hey, this is going to give me some information on what's going on inside of your socket. And it was an instant relief for her, which was great. So when looking at the sensors, though, when I watched her stand up, watched her walk back and forth, I noticed that the anterior and medial tibial sensors, remember I had 3, I had 1 lateral, medial, and anterior right over the tibia. The medial one and the anterior tibial one were much higher pressure readings than the lateral sensor. And I was anticipating in the reading that I would get a really high medial and lateral, but not center, right? Because that center one's over my tibia. I don't want a lot of pressure on that tibia. I want a good AP hold, but I don't want excessive pressure. And as she tightens that dial, I should be able to see those medial and lateral pretibial pads show a higher pressure. But it didn't. My center and my medial one were significantly higher. And so watching her walk and looking at those sensors, I realized that my medial window, my medial section of my tab was actually too close to my tibia, and that my placement of that cutout was not in the ideal location. Thankfully, this was caught while in the check socket fitting, and so that was moved just more medial, so it wasn't banging into that medial tibial flare. Again, Chris has sensation, but it is very fuzzy at times. Sometimes she struggles with being able to tell me exactly where, again, but it was really great to realize that my center and my medial panel were lighting up significantly brighter. I took off her liner like we normally do when we're clinicians and looked at her skin, and it all had a nice pink to it, and maybe a little bit more on the medial. I could see that it was a little more red, but in her actual readings, it was picking up that slight little change, that slight little difference between the medial and lateral pull of those pads. And so that let me know that I needed to move my placement, my cutout for my window over in the next check socket fitting, and to optimize the stringing also that you do in a BOA system to make sure you get a nice even compression from those pads. And then another area that I optimized with using the Insight system is that gastroc panel, that gastroc pad. I ran a strip right across that. And I noticed that the gastroc sensors, again, were not showing an even distribution over the pad. There was high pressure on the center and on the top of that pad, but very little on the bottom. And I realized that in relation to her limb, the pad was sitting just canted off of it because of the shape that the pad had been skived by the technical team. So I pulled that pad out and changed the skive and changed the shape of the pad and mounted it back in there, and it was significantly more flush to her limb, and then was able to get a nice even distribution of reading. I tell people that when I see redness pop up, redness is not a bad thing on the scan. It just shows even contact. So I like to see an even amount of whatever the color is. It's normally a red when we have a nice even distribution of pressure. And so that's what I'm looking for, is to see that evenness all throughout, knowing that I have that total contact achieved. So I changed the skive of my gastroc pad, which is kind of hard to see, right? I can't get in there and you know, you can kind of stick your fingers around in the pad, but you can't really get a true idea of how tight is the top of the pad or the top of that window compared to the bottom, especially with doing Revo fits in a check socket, right? When you're doing those panels, you have to wrap that check socket in fiberglass. And so you lose your visibility. You lose your ability to see how much you're tightening or how they're donning and sliding in and all of that. You lose that because it has to be wrapped in fiberglass to contain the BOA system for those check sockets. So although I always fit a clear check socket first before I do the BOA system, sometimes when you put that BOA on, it just changes the distribution of those tissues significantly than when you had them in the standard check socket. So it's really helped with that because, again, the visual is gone. All right, I think we can go to the next slide here. And then
another question from Massimo. So is it possible to use the sensors only in transfemoral and transtribual prosthesis, or they can also be applied to sockets for hemipelvectomy amputation? I guess is higher up, right?
Yeah, I personally haven't used them on a hemipelvectomy. I have a hip disc artic, but I haven't used it in there, but I don't see why it couldn't be. You put the socket in there like you traditionally would and lay your sensors in there. And yeah, I don't see why that would be an issue at all. So.
Okay, brilliant. Well, we've got video back online. So Cass, we're just, maybe you can just talk us through what we're going to see now.
Sure. We can go ahead and play this video. This is Chris walking in her new socket. She actually felt confident enough for the first time to use a cane instead of her walker, which is a great step for her. Again, in that confidence level, she's still needing extensive physical therapy to continue to help with her gait and her ambulation. That knee joint is so compromised. I mean, it's set in 18 degrees of valgum, and I can move it into more valgum from there, right? And so it's definitely a lot of therapy for strengthening those quads, and me constantly kind of changing her alignment as she goes to therapy and making sure I keep up with her also is really, really important for her. She needs a lot of cueing when she walks. She can tighten those quads and improve her gait, but she doesn't remember to do that a lot. So it's a lot of cueing for her. But for the first time, yeah, she was able to feel confident enough to let go of the walker. Again, is her gait beautiful in this video? No, it's not, and I know that. And it's being patient with your users, but also having this data to reference back and say, okay, how much pressure is she getting on that medial side with that valgum that she's got? How is that doing? Is she comfortable? Does she need more support? Do I need to try to inset that foot even more to get her back over? And so it's really great to have that visual reference besides just my clinic notes. Obviously, we take videos and we compare and we show before and afters of people walking the first day in their prosthesis compared to 2-3 months later. But having this now lets us really have a good idea of where they start. So yeah, that was Chris.
That's great, Cass. Thank you. Well, I mean, we've got a few more things to go through with you shortly. So more questions coming through, which is great. So what I'll do is I'll just expand a little bit now on the 12 patient case study that we've done. This was part of a 2-center study that we did with Cass's group and also Della Torre. And we had a protocol where we were looking at a period of time where we had patients pre-fitting, at fitting, and then post-fitting. And you can see here the various protocols here that we're working on associated with both health, function, satisfaction, and likewise patient pain. So this study is still ongoing, but we do have some interim results that we wanted to share with you today. So if I could go to the next slide, please. I just explained that basically the protocols that we're using was AMPRO, which of course many of you are going to be familiar with, EQ5D5L, which is a patient health and quality of life assessment score. Timed up and go, so type was very important to that. And then likewise, we were using the McGann patient satisfaction form, which was really important to us in terms of understanding not only is it bringing efficiency to the patient fitting process, but are we including increasing the K level potentially, which is very important from a billing perspective, but likewise is the customer happy, patient happy. So if we could go to the next slide, please. You can see here that we have 12 people in the study. 6 have gone through to the post-fitting assessment. A number have gone through beyond this 7-stage phase now, way beyond the 7th day stage. But I'll just go to the next slide, if I may. I just explain the results to you. You can see here that the green panels are really the ones that are demonstrating the improvement scores. So you can see that we had 2 patients that actually went up in a K level, one from a 4, as you can see, from a 3 to a 4, and likewise the other 2 remained as they were at 4s. And then you can see that basically when you go across the scale, that there were improvements for the majority of patients, and the ones that were demonstrated in red there, where there was a fallback, that was actually where the patient was using a different device. So we had the same socket, but the patient was using a running blade or experimenting with the running blade there. So of course that demonstrates a lot of the issues that they were having in terms of their feedback. So overall, the results have been very, very positive. And Cass, you obviously were looking at this study as well. I mean, does this bear out what you've been experiencing with your patients as well?
Yeah, I have noticed that with just with a more comfortable socket, with a better fitting socket, people are going to do better. That's no question about it. So definitely I've seen K levels, maybe not jump a whole K level, but absolutely improve in their mobility. That's without a doubt. And then with their satisfaction, people feeling more just happy with their experience of their care, with feeling understood and heard. So yeah, absolutely, I've seen these changes.
Yeah, great. So you can see that on the left-hand side there that everybody was either improved on their AMPRO score or stayed the same. And on the right-hand side, in terms of patient satisfaction, with the exception of the person that was obviously using the running blade, everybody had increased patient satisfaction as well, up to 140%, as you can see there, which is very encouraging. So if we could go to the next slide, please. Yeah, so Cass, just to talk about some of the patient outcomes that you've experienced as well, if I could just hand back to you, maybe just expand on some of those experiences, that would be really helpful.
Sure. So this is Erie. He is just a great patient. Wanted to highlight him really quick because he's not a crazy unique case. He's a classic lower K3 patient, standard ischial containment. He has some volume fluctuations, didn't want the bulkiness of a BOA, and was okay to put a sock on every once in a while. So, and he felt the most confident using a lanyard system. So once again, we went with what he felt confident using. And actually his case kind of jumps to a question that's in the chat about asking if I have experimented with socket alignment changes to redistribute pressures. And absolutely. So with Erie in COVID times and quarantine, he spent a lot more time at home, not as much time out and about and walking. And so when he came in, I noticed his alignment was not ideal. I think his hip flexion contracture got a little bit more progressive, and that needed to be rectified in the socket. You can see his weight line is a little bit more behind that knee than then is ideal. And so I put the Insight system on him to look at that and try to fine tune those alignment issues. So without a doubt, it is not always just a socket issue, right? We can have a perfect fitting socket, but if your alignment's off, then your socket's no good, right? And so it absolutely has been helpful in seeing that. Sometimes I'll just tinker around and really plantar flex a foot or really dorsiflex a foot just during static standing to kind of see those changes in the system. So yeah, definitely helps with alignment changes. So yeah, this is Erie. We can click on over to the next slide. Erie has been using a prosthesis successfully for 4 years, and I've been treating him kind of since the beginning. So I know his limb, I know his shape, I know how he likes his sockets to fit, and he recently went on a new medication and dropped about 40 pounds and has really taken control of his diabetes. So I had to recast him for his latest socket. And when I made the previous socket, I didn't have the Insight system yet. And then when I made this socket for him this time around, I thought, well, you know, I can fit him, no issues. I know him, but let me use the Insight system on him. And I had never put sensors all along the ischial seat, so I wanted to try that. And Erie's a really easygoing patient, and so he was very patient with me while I tinkered with it and moved things around and let him see what I was doing the whole time also, just because again I had never put in sensors all along the ischial seat and your brim essentially. And so what's great is that Erie could see that, you know, and see the effort we were going through to make sure that it was an optimal fit and optimal contour. And what I really liked was being able to show him the pressure on the side when he doesn't maintain a good volume and the pressure on that brim when he doesn't wear his socks appropriately. And that allowed us, I think, to do better education than before. Before I had said, hey, when you feel pressure on that medial groin region, that's a sign you should probably add a sock. You're dropping into that socket, right? And so for him to be able to see, oh, the sensors light up really red when I don't have my socks on, or when, you know, when my leg feels loose, yeah, I do get that groin pressure. Oh, I'm dropping in. This is what dropping in looks like, right? He can visually see it. And then we add a sock and sure enough, he can visually see, oh, right, the pressure on my groin goes away when I maintain my proper volume through using a sock. And so he's become much, much better about that. And so by using the Insight system, I went back and I compared how many visits I had done with him compared to the previous socket. And I had made him 2 or 3 other sockets prior to that. So and I've worked with Erie for a few years now, and it was really interesting just seeing the change in appointment time that it took. And so for his socket before that, I had 5 visits to delivery. So that was an initial evaluation and casting, check socket fitting, a second check socket fitting, a dynamic alignment, I believe, and then delivery. So that's 5 appointments. But with the Insight system, I was able to use my first check socket, contour that brim, really work on that brim, getting a nice fit, and I didn't need to do a second check socket on him. And then in that 3-month warranty window after delivery, he had 4 follow-up visits with me during that time without using Insight, and then with the Insight only 2. And then again, 3 months after that warranty period ended. So just a significantly reduced amount of visits for him. He relies on someone for transportation. And so that, you know, not having to come in as much is definitely beneficial for him. The times that he had come in before without the Insight system were primarily for volume adjustments and saying, hey, well, we can add a pad, but I know that you kind of swell up some in the morning, so you may need to pull this pad out, or you should add a sock. So it was that education again for him. I think we can pop over to the next slide that will just show kind of some of the basics. Yeah, so for me, it saved me visits. The first round of that replacement socket was 12 visits total from the start to 6 months after delivery. And then it was 8 while using the Insight system. Does this happen with every single case? No, but does it happen? Yeah, it happens. So if I can save 4 appointments, that's a significant time. That's so many other visits and patients or projects that I can work on, getting notes done, all of those areas that just can bog us down sometimes with follow-up appointments that we're chasing volume, right? Especially for individuals that are on diuretics or have a history of just volume fluctuation. So it helps me, it helps the technical team in doing one less check socket for Erie. And some could argue, well, you get paid for 2 check sockets, so why not do another one? Why waste my time? Why waste the patient's time if I can be seeing other patients, talking to referral sources? 1 check socket should not make or break your practice. And if it does, then that's probably something you should work on. So yeah, to me, if I can get something done in 1 check socket, I'm going to absolutely do it. Again, Erie would relies on his brother to bring him to the office visits. And so his brother would sometimes have to take off work to drop him off. And so if I can reduce that stress on him and his family, then that's important. And for Erie's case, it took 35% fewer visits for us to get a successful socket fit. And so for his case, I absolutely was able to, just my curiosity piqued. And I said, well, how long did it take me to fit him last time? And how many times did he come in after that? And then looking at it this time, it was really just interesting to compare. I wanted to start doing that and going back to previous patients that I've used it on and just seeing, how often does this happen? I find that sometimes when I use it, my appointment might go a little bit longer the first time around though, because patients are so intrigued in what's happening in their socket. They are so hungry for that information because they've never seen it before, they've never experienced it before, and they want to look at it, they want to know, they want to be involved. And it really does help on the education side to make them just part of the team with you again and giving them confidence and reassurance. So I would say I definitely say visits with it, but that first time you use it with a patient, definitely expect them to want to be looking at it and hovering over the iPad and spinning their socket around on the screen and zooming in and out and touching all the pressure sensors, which is great. I love when they become involved and become an advocate for their care. So yeah, I think we can pop over to the next slide. So some of the things that I know how it helps is it lets me, again, immediately get feedback from watching them walk and inspecting their limb afterwards. Oftentimes we would take off the socket, we'd look at their skin and say, oh, it looks a little pink here, it looks a little red there. I can see that the second they stand up where the pressure distribution is going to be on their limb. I don't have to wait for them to walk back and forth, back and forth, back and forth, get an irritation or say, oh, wow, ow, that's kind of painful. The more that I walk, I can see where it's highly likely that they're going to get that skin irritation or that alignment change that needs to happen. It's really helpful for the resident prosthetist that we have on our team too. She didn't have as much experience before coming into the field, like shadowing at a prosthetics place or anything like that. And so her coming here to us is really kind of the first time besides school that she's worked with anyone that uses a prosthesis. And so she definitely needed a lot of training and learning, but I think this has really helped to improve her feedback and her getting that information. She's still working on interviewing patients and asking them about how things feel. And so this gives her that advantage really to continue to create better sockets and improve fit and improve alignment. And then that next point, improving patients' understanding of when and how to use socks. We talked about that, showing them what bottoming out looks like or showing them what pistoning looks like. Also with rotation of a socket, when they don't have their volume managed properly, we get rotation that happens. And so you can see that as well. With helping train Revo users, I had those sensors in there for Chris, and Chris always asked me, well, how tight should it go? And what's our answer? Well, tight enough to where it's comfortable, but not so tight that it's uncomfortable, right? So how do we quantify that amount? And so using the insight helps them see, okay, I've got a nice even distribution when it's about this tension that I'm feeling, the image that it's showing me, that looks about right. Okay, if we tighten it down more, oh, well, I'm really getting high pressures over those areas. And that does feel a little uncomfortable. And so it gives them a visual cue to their dial tension also. And then, yeah, we've run a bunch of the McGann feedback form and socket comfort scores, and we've just seen improvements in their comfort and their happiness with their socket with using this. So, yeah, I think What else do we have? Oh yeah. Okay. This is something that I get really excited about because it's been a huge help for us in clinic. So we have, especially with COVID happening, we've had a lot of people move out of New York City. And again, we're about an hour north of New York City. So we've had a lot of people come up this way just because they didn't feel comfortable living there. They wanted to get out. And we've had a lot of patients that have come from other facilities needing care. And one of New York's rules for some of their insurances is that if we want to put in for a replacement socket, we have to submit measurements of their limb when they had received their previous socket and measurements of their current limb that show a discrepancy, that show a difference. And so we've had insurance companies say, hey, I need measurements of the limb from this date. And we're like, well, this is a new patient. We don't have those measurements. And so what do we do, right? And the really cool thing is that I've been able to take the old socket that the patient is using, if they need a socket replacement, put it into the scanner, get that internal scan, get quick measurements of the inside of the system and compare that to measurements of the residual limb over the liner that they're using and being able to show that discrepancy. How else would you do that, right? You would have to pour up that socket with plaster, get their socket out of there. Hopefully it comes out nice and easy when you pull it, and then take measurements of a positive model, right? That would take forever. So for us, it gives a really good baseline, and it gives us measurements of their current socket. And that, again, we can print off. It gives us all the quantifiable documentation for insurance, because of course that's an uphill battle for us all. And we've actually been able to use those PDFs that the app will print out as supporting documentation for our insurance claims. And so we've been really successful with adding those. We haven't been told don't add them. Obviously, there's not a billing code for doing more documentation, right? But it doesn't hurt. It really just helps to maintain a consistency of care and always getting those numbers, because you never know when they're going to call up and say, wait, what do you mean? Even for those Medicare patients that you want a good history of having documented volume changes, it's really important to be able to show those consistently. So thankfully, we have a really great clinical assistant here at our practice, and her role is whenever we have a new patient come, she will help get some of their baseline information, height, weight, and she will scan that socket in. So we have a baseline of their socket. She will explain the sensors, which is really, really great, because she takes her time, while maybe if I'm running behind with another patient, she can go in and get started with telling them, hey, we'd like to get a visual of what the inside of your socket's looking like. We're going to put some sensors on there, and we're going to talk through what this looks like and kind of what's going on. And she'll also prep any of our check sockets that we're going to fit. So we will, she'll put the sensor strips in certain locations. If I say, you know, I want this setup or this setup, she'll set them in there, get it scanned, get them put into the iPad, and have it all ready for us to go. The setup maybe takes 5 minutes, but it's still great that she's able to do that for me. So it definitely has been a really unique experience for our clinic, and it just changes how I look at things, how I practice, how I do my alignment changes. And gives me that feedback and that knowledge, and for the patients as well, giving that to them. So, yeah.
That's great, Cass. Thank you. So I'm just about to launch our poll. We'd like to just get your feedback from today's presentation while we go through some Q&A. So there was one question that came through, Cass, which was from Amira. Which was basically about, she said, I noticed that I noticed the pressure was persistent at the posterior proximal distal anterior, even after the sock was added. Have you experimented with socket alignment changes to see if those changes can redistribute total contact?
Yeah, I think I touched on this a little bit while some technical things were going on in the background, but definitely, I mean, with Erie's case, I knew when he walked in that his hip flexion contracture had gotten worse and his alignment wasn't ideal. And that last time he was in with those pictures from that, I was working on alignment changes with him to get that more optimized. And absolutely doing, you know, like I said, you can have the most perfect fitting socket, but if your alignment's off, then it's useless, right? And so without a doubt, you can easily see if you've got significant more pressure in one area than the next, and you change your socket alignment, it's very easy to tell. It's very, very telling. I would say I can probably tell more about alignment than anything from the get-go. Absolutely.
Okay, excellent. Well, very grateful to everybody for completing the poll. If you could just take 30 seconds just to complete the poll while we go through, that would be really helpful. We've got more time today, so if anybody has any further questions, please either raise your hand and we can bring you up onto the screen, or pose your question via the chat channel. That would be great. So great opportunity. If anybody has any questions to ask, please fire away. So Cass, just while we're waiting for anybody to come through, we've got a few events coming up now. We've got the AAOP event taking place next month in the US, where I guess you'll be doing a similar type of presentation to today, and then ISPO and AAOP coming up, AOPA coming up. So lots going on. Yeah,
there is. It's exciting. It's just unique in the fact that there's nothing really like it that I've been able to use. I mean, I remember going and learning from different clinicians, and in school where we would rub the inside of a check socket with Crisco, which is lard. I don't know. Do you guys have Crisco in the UK?
No.
It's like a clear vegetable oil lard type of substance. And so you would rub that on the inside of your socket and then have them stand in, and wherever you would see the butter move to, that's where they didn't have pressure, and vice versa. And so it's a significant improvement to some very old school techniques that are somewhat helpful, but not really great when you're trying to clean butter off socket.
Yeah. And then you mentioned, Cass, that you were working with your resident, which I guess for people outside of the US, that would be like a graduate trainee from a university, right? So with that working with that person, do you find that this sort of the adoption of the technology was relatively easy for them? I mean, having dealt with people, but obviously, as you do from all stages of their career, do you think this is a relatively easy system to adopt?
Yeah, absolutely. Amira asked a question that said, without a clinical assistant in the office, how much would you estimate it takes start to finish for a new clinician to perform the full insight process? So yeah, with my resident and me just, giving her a quick training, you get your socket, you put your sensors in, you put it in the scanner, you pull it out, and you attach it to the Bluetooth, which syncs to the iPad. It's very straightforward. So I would say prep time, maybe 5 minutes. And then from there, you go through your fitting just like you normally would. You go through, you make your adjustments, you adjust your socket, you change your alignment, and then you continue on through there. So again, I think maybe the actual setup, the prep time, about 5-7 minutes, maybe, if you decide you want to change your sensor placements or add a new one or something like that, which you can absolutely do. And then just be prepared for your patient to be really interested and involved. And, you might have them take up a little more time than usual for that. So in general, if you know how to work Bluetooth, you can do this. Like, it's turning Bluetooth on, empowering things on, and making sure your iPad's charged. So it's pretty straightforward in terms of the actual technology effort that the clinician has to go through, without a doubt.
Very good. So that really dealt with Amira's second question there. So again, we've got a couple more minutes now before we wrap up today's webinar. We've got more webinars coming in the series, so please feel free to register for those. They're different flavors each time we do them. So if anybody has any further questions, please feel free to either post them to us in the chat channel, or obviously you can respond to the email invitation. We'll pick those emails up if you want to fire them in. And again, grateful to those people that completed the poll. We're nearly complete. We've got 18 people out of 21 have now finished, which is great, as people are dropping off. So great. Well, I guess there's no more questions coming through, and remains for me to thank you, Cass, for your time and support today, and your continued good work with your patients. And likewise to Fred for giving us the excellent demo. And great, well, we'll see you at the next webinar. And for those that are going to the AAOP event, we'll see you online next month. So great. All right, thanks very much, everybody.
Thank you very much, everyone.
Thanks so much.